Start, sir.
Good morning. We are already few minutes late due to establish the link. Today's discussion is on genitourinary tumor. Students are audible to me? Hello?
Yes, sir.
Students are audible to me?
No, sir. They can hear you. They can see your presentation.
Okay. The renal first topic is renal parenchymal neoplasm. Kidney is very important organ which harbor neoplasm. Depending on the different tissue component of the kidney, there is long list of tumor arising from renal collecting tubule, renal vasculature, renal capsule, glomerulus, and other tissue component. But basic classification is benign and malignant. Malignant tumor is classified as primary and secondary. With the use of liberal CT, MRI, benign renal masses are being detected more frequently. Benign renal tumor includes oncocytoma, angiomyolipoma, leiomyoma, lipoma, hemangioma, and juxtaglomerular tumor. Of these clinically important tumor are, এই এটা লক হয়ে গেছে কেন এই দেখো দেখো এই স্লাইড চেঞ্জ হচ্ছে না হুম One important benign tumor is oncocytoma, characterized by epithelial cell with eosinophilic cytoplasm called oncocyte. Solitary unilateral tumor usually presents with gross hematuria and frank pain in 20% cases. Otherwise, it presents as non-specific symptom and diagnosed on appropriate imaging. No characteristic features on ultrasonography MRI except solid renal mass. Nephrectomy is treatment is rarely turned into malignant. Another important benign tumor, though rare but clinically significant, which may be unilateral or bilateral, asymptomatic, may be associated with tuberous sclerosis. Major histochemical component, mature fat cells, smooth muscle, and blood vessel. USG and CT image by CT scan is a negative density minus 20 to 80 Hz spleen, which is pathognomic of angiomyolipoma. Asymptomatic tumor less than 4 centimeter need follow-up with CT or USG biannually. Tumor more than 4 centimeter with moderate to severe symptom, mainly bleeding or pain, should undergo renal sparing surgery or renal arterial embolism. Recent data suggests immunosuppressive agent such as sirolimus is effective in treating angiomyolipoma in patients with tuberous sclerosis, and present with pain or hematuria. Most important renal malignant tumor is adenocarcinoma of the kidney, that is called renal cell carcinoma. The renal cell carcinoma accounts for roughly 2.8% of adult cancer and constitute about 85% of all primary malignant renal tumor. Asians appear to have lowest incidence of RCC. RCC vascular tumor tend to spread either direct invasion to the renal capsule or into perinephric fat and adjacent visceral structure or by direct extension to the renal vein. Approximately 25 to 39% of the patients have incidence of metastatic disease. Most common site of distant metastasis is lung. However, liver, bone, which is usually osteolytic lesion, ipsilateral adjacent lymph node, adrenal gland, brain, opposite kidney, subcutaneous tissue are the frequent site of the disease distant spread. RCC originates from collecting tubular epithelium as evidenced by electron microscopic study. This tumor occur with equal frequency in either kidney and distributed equally in upper or lower pole. Grossly tumor is characteristically yellow to orange because of abundant lipid. RCC usually do not have true capsule but may have pseudo capsule with compressed renal parenchymal and fibrous tissue and inflammatory cells. Histologically, most RCC are classified into following pattern: papillary, clear cells, chromophobe cells, collecting duct, neuroendocrine, and unclassified. Sarcomatoid cells are spindle-shaped, form sheets or bundle. This latter cell type rarely occur as a pure form. It is most commonly as a small component of either clear cells and papillary cells. Patients with sarcomatoid cells are usually very bad type of tumor and associated with very poor prognosis in spite of all modality of the treatment available for renal malignancy. There are different risk factors which is responsible for renal cell neoplasm. Male to female predominance 3 to is to 2. Typical presentation is 50 to 70 years. Tobacco exposure, relative risk 1.4 to 2.5 compared with control. Obesity is a risk factor. Hypertension, long-standing hypertension, regular use of non-specific anti-inflammatory drug, aspirin and acetophenone, which are not associated with any risk factor because these two drugs are very commonly used. Retroperitoneal radiation therapy, relative risks are low. End-stage renal disease, which particularly develop after long-standing dialysis, and patient with different medical disease, which causes end-stage renal disease. Certain family syndrome. Symptoms, roughly, renal cell carcinoma presents. One group is asymptomatic renal mass, symptoms of localized disease, obstructions of the inferior vena cava, and symptoms of the systemic disease. Symptom of localized disease, hematuria, flank pain, abdominal mass, usually called classical triad for renal cell carcinoma, usually found only infrequent cases, less than 10% of the patients. Patient may present with perirenal hematoma. Obstructions of the inferior vena cava, as inferior vena cava drain the blood from periphery. Obstructions of the inferior vena cava cause bilateral lower extremity edema and non-reducing right-sided varicocele. So sudden onset of right-sided varicocele in young male or even old male should give rise to suspicions of the renal cell carcinoma because varicocele is commonly found on the left side. Symptom of systemic symptom. If patient develop pulmonary metastasis, persistent cough, sometimes with hemoptysis, bone pain, the characteristic malignant bone pain is severe pain, not responsive, usual advice analgesic drug. Cervical lymphadenopathy. The characteristic of the lymphadenopathy is usually hard, fixed, unlike inflammatory lymphadenopathy that commonly occurs in tuberculosis. Constitutional symptom, weight loss, fever, malignancy, paraneoplastic syndrome. Paraneoplastic symptoms are important symptoms found in different type of malignancy. Tumor secreted some factor, it produces different symptoms and usually not associated with advanced disease or metastatic disease. That is primary When primary tumor is treated, paraneoplastic syndrome usually gradually disappears. One important paraneoplastic syndrome is hypercalcemia in patients with RCC, either due to paraneoplastic phenomena or osteometastatic involvement of the bone. Reasons behind the paraneoplastic phenomena: parathyroid hormone like peptide, 1,25 dihydroxycalciferol, and prostaglandin. Non-metastatic hepatic dysfunction, the Stopper syndrome, is found 3 to 20% of the cases. Almost all patients with Stopper syndrome suffer elevated alkaline phosphatase level. 60% have prothrombin level high or hypoalbuminemia. 20 to 30% have elevated serum bilirubin or transaminase level. Hypertension associated with RCC may be secondary to increased production of renin directly from the tumor, compress or encasement of the renal artery or its branches, effectively leading to renal arterial stenosis or arteriovenous fistula within the tumor. As tumor vessels are usually thin, fragile, there is easy possible to fistula's formation between artery and vein. Less common causes include polycythemia, hypercalcemia, ureteral obstruction, and increased intracranial pressure associated with cerebral metastasis. Less common paraneoplastic syndrome associated with RCC, Cushing syndrome, hyperglycemia, galacturia, neuropathy, neuromyopathy, clotting disorder, and cerebellar ataxia. Systemic symptoms such as significant weight loss, cachexia, poor performance status at presentation, like any advanced malignancy, also found in patients with RCC, as do physical examination finding palpable mass, lymphadenopathy, non-reducing varicocele, and lower extremity suggest edema, suggest venous involvement. Physical examination, there is characteristic weight loss, palpable lymphadenopathy, which is characteristically hard, fixed, non-reducing varicocele, lower extremity edema, superficial vein prominent, and deep tendon reflex absent. Diagnosis: USG is simple investigation, usually available and cost effective, but renal cell carcinoma has wide variety of sonographic appearance, solid, partially cystic, may be hyper, iso, hypoecogenic due to surrounding renal parenchyma, tumor pseudocapsule, sometimes we visualize with ultrasound as a hypoechoic halo. CT scan, a dedicated renal CT scan remain significant single most important radiographic testing for delineating the nature of renal mass. In general, any renal mass that enhanced with intravenous administration of contrast material on CT scan more than 15 Hounsfield per unit should be considered as RCC unless booked otherwise. In 10 to 20% solid renal mass, CT findings are indeterminate. Additional imaging, biopsy, surgery is needed to establish a definite diagnosis. Difficult to distinguish RCC in CT from benign renal neoplasm, including oncocytoma and FAT4 angiomyolipoma. MRI can be reserved primarily for the patient with locally advanced malignant disease, equivocal venous involvement, allergy to the contrast material. Is biopsy required? This is important question. Renal biopsy is now being considered more frequently, particularly in patients, potential candidate for wide variety of treatment options ranging from observation to surgical excision. There is suspicion of renal abscess because small renal abscess sometimes mimic renal tumor on CT when RCC must be different from malignant metastatic malignant disease, renal lymphoma, where treatment policies different from primary renal malignant tumor. Other investigations, liver function parameter sedimation rate, alkaline phosphatase, lactate dehydrogenase, serum calcium. CT finding of venous involvement includes venous enlargement, abrupt change in the caliber of the vein, filling defect, and demonstration of collateral vessel. So when collateral vessel is demonstrated, that is the vena cava obstruction is usually long-standing. Difficult to interpret right-sided tumor, shorter length of vein, and mass effect from tumor combine to make detection of the tumor thrombus difficult. Echocardiography now is best reserved for patients with equivocal MRI or CT finding or patients who cannot tolerate or other contraindication to cross-section imaging. Transesophageal echocardiography appeared to be accurate for establish cephalate extent of the thrombus because renal vein thrombus extend to the IVC and IVC thrombus may extend behind the liver also into the atrium. The disadvantages, it is invasive, provide no distinct advantage over MRI or CT in pre-operative setting. Staging of level of IV thrombus as follows. 1. Adjacent to the renal vein, ostium of the renal vein, extending up to lower aspect of liver, involving intrahepatic portions of the IVC below the diaphragm and IV extend above that diaphragm. The staging is very important. Patients with higher stage may require help of cardiothoracic surgeon and may require cardiopulmonary bypass to remove entire thrombus which extend into the atrium. Enlarged hilar and retroperitoneal lymph node 2 centimeter or more on CT almost always harbor malignant change. Many smaller nodes prove to be inflammatory or reactive rather than neoplastic. MRI can add specificity to the evaluation of retroperitoneal lymph node by distinguish vascular structure from lymphatic one. Positron emission tomography has also been investigated for patients with high-risk metastatic disease. It provides dual information, the biologic information as well as anatomic information, particularly when PET combined with CT scan. At present, it is best role for equivocal finding on conventional imaging. Biopsy of the primary tumor and or potential metastatic site is also selectively required as part of staging process. Metastatic evaluation, bone skin scan can be reserved for patients with elevated serum alkaline phosphatase, bone pain, poor performance status. Chest CT of patients with pulmonary symptoms or abnormal chest radiography is simple chest X-ray can detect the lesion when lesion is more than 2 centimeters, usually classically described as cannonball deposit in the periphery of the chest field. TNM classification. This is well accepted classification for renal tumor, usually based on size of the tumor, lymph node, and metastatic workup. Treatment. Renal cell tumor is a surgical disease. Every attempt should be made to remove tumor surgically. As unique features of the renal tumor, renal cell carcinoma is it is chemo resistant. When disease localized to the kidney, surgical removal of early stage lesions remain only potentially curative therapy available for RCC. Radical or partial cystectomy are primary treatment for localized disease. Goal is to achieve removal of the tumor and to excise wide margin of normal tissue. Radical cystectomy entails en bloc removal of the kidney in for enveloping fascia called aorta fascia, including ipsilateral adrenal, proximal one half of the ureter, and lymph node to the area of transection of the renal vessel. Areas of an incision provide optimal access for radical nephrectomy as anterior subcostal, polyunilateral chevral, thoracoabdominal incision, particularly when a very large tumor arising from upper pole, occasionally midline incision, which are the other classical flank incision. It can be successfully performed by laparoscopically or robotic. Palliative nephrectomy usually done locally advanced case for bone and hematuria. Small renal mass less than 3 cm, particularly in elderly patients, can be observed with regular interval CT or can be treated by radiofrequency ablation. Targeted therapy as tumor is resistant, patient with advanced disease, and with the available knowledge of different tumor promoting factor, nowadays this modality of treatment have been attempted, particularly for metastatic disease. There are significant progress in the development of several angiogenetic agents an inhibitor of the tyrosine kinase, and other cell cycle activator for treatment of the metastatic RCC in different settings and routinely used in practice. Prognosis, patient is Prognosis of the patient most clearly related to the stage of the disease. Recent study report 5-year survival rate for patient with T1, T2 disease 80 to 100%, with stage 3 50 to 60% range. Patient presented with metastatic disease have poorer prognosis with only 16 to 32% 5-year survival. So this is in short about renal cell tumor. Next we pass on important tumor of the urinary tract, that is bladder tumor. Bladder cancer is second most common cancer of the genitourinary tract, account for 7% of new case in male, 2% of new case in women. Cigarette smoking account for 65% of the case in male, 20 to 30% is women. Positive agents are thought to be alpha beta naphthylamine, which are secreted in the urine of the smoker and cause DNA mutation. Occupational exposure accounts for 15 to 35% of the case in men, 1 to 6% in women. Worker in chemical dye, rubber, petroleum, leather, and printing industries are increased risk. So there is also protocol for annual health checkup of the worker exposed to that high risk profession. Specific occupational carcinogen includes benzidine, naphthylamine, 4-aminobiphenyl, and latency period between exposure to tumor development may be prolonged. 98% of the patient with bladder cancer epithelial origin, that is transitional epithelial cell tumor called TCC, 5% are adenocarcinoma and squamous cell carcinoma. It is broadly classified into non-muscle invasive, comprise 75% of the tumor, and 30% bladder tumor, muscle invasive at presentation. Non-muscle invasive tumor, when confined to the mucosa, we call it type TA. When confined non-muscle invasive tumor invade the lamina propria, is classified as T1. Tumor most commonly appears as a papillary or exophytic lesion. Less commonly, they may be sessile or ulcerated. The papillary tumors is usually superficial in nature. Sessile tumors are often invasive. Carcinoma in situ is recognizable as flat anaplastic epithelium. The urothelium lacks normal cellular polarity and cell contain large irregular hyperchromatic nuclei with prominent nuclei. Tumor is highly malignant and aggressive in nature. Painless intermittent hematuria, most common presentation. The intermittency may be sometimes more prolonged, so very often patients forget their second unless second incidents occur or think that the symptom is already cured. So patient attention, any hematuria patient presented with painless status should be properly investigation to detect the possibilities of the tumor. Patient may have increased frequency and voiding, the urgency which confused as UTI, urinary tract infection due to carcinoma in C2. Patient may have bone pain when disease is advanced to metastasize in the bone. Anemia signified significant hematuria, so needs blood transfusion prior to treatment. Azotemia, when obstructive uropathy develop with involvement of the uretary orifice, or patient may have concurrent chronic kidney disease that needs proper evaluation. On parrectal examination, induration at the base of the bladder suggests invasive tumor. Hepatomegaly, supraclavicular lymphadenopathy are signs of metastasis. Patient may also present with back pain and pathological fracture from bony metastasis. Diagnosis: white light cystoscopy is gold standard for diagnosis of the bladder tumor. It detects tumor, locations of the tumor, or number of the tumor, and urinary orifice visible or not. Usually, most of the tumor develop on the posterolateral aspect of the bladder. Other important sites, fundus and anterior wall of the tumor. Flexible cystoscopy can be used as an office procedure. Cystoscopy with porphyrin dye called blue light cystoscopy more sensitive to detection of the CIS, carcinoma in situ. Tumor cytology: tumor cells are exfoliated in the urine, which can be collected by centrifuging voided urine examination for malignant cells. Positive cytology: when tumor is not endoscopically visible, suggestive of the tumor, and proper imaging and follow-up is required. CCT of the abdomen and pelvis. for upper tract evaluation and staging of the muscle invasive tumor and metastatic workup. It has been found patients with transitional cell carcinoma of the bladder risk of developing transitional cell carcinoma of the upper tract, that is ureter and renal pelvis, in 2 to 4% of the patients. Patient under treatment of bladder tumor need periodic imaging to detect development of TCC upper tract at earliest time. The staging of the bladder tumor that is demonstrated diagrammatically, most commonly used staging system, American Joint Committee on Cancer, based on descriptions of the primary tumor, status of the lymph node, and metastatic site. Treatment or management of the bladder tumor. Endoscopic management is fundamental treatment of bladder tumor. That is, transurethral resection is the gold standard for superficial bladder tumor. It is done under regional or general anesthesia. It removes all visible tumor that is visible by endoscope, provides specimen for pathological examination to determine the stage and grade of the tumor. Resections of diverticular tumor present significant risk for bladder wall perforation or accurate staging is difficult. Anterior wall tumor at the difficult to resect, minimal bladder fill, and manual compressions of abdominal wall are the technical part that is required, which bring the tumor towards resectoscope and facilitate resection. Nowadays, long resectoscope with telescope at different angle available to manage this difficult type of tumor. Risk of perforation is high in anterior wall tumor resection. If tumor appears to be muscle invasive, biopsy from the border and base is to establish invasion may be performed instead of complete resection because this tumor actually requires cystectomy after biopsy confirmation. Repeated TUR. After TUR P of initial, when histopathology is available, it is sometimes repeated within 2 to 3 weeks. Sometimes it is indicated when complete resection is not possible at first stage because tumor is very large, it is anatomically inaccessible, and medical instability, that is, patient has different medical comorbidity which limits the time of surgery, so it can be performed in 2 stages. Sometimes it is done as stage QRP. If repeat QRP is justified in high-grade tumor when muscle tissue absent in initial QRP specimen for staging of the tumor, subsequent treatment policy. Because the muscle tissue free of the tumor, the stage is superficial bladder tumor and muscle tissue contained tumor, which is called muscle invasive tumor. Treatment policy is entirely different from non-muscle invasive tumor. Laser therapy, it is minimally invasive ablation tumor up to 2 to 2.5 centimeter. ND-YAG laser is the use of tumor ablation. It is expensive, but bleeding is negligible. There is no risk of operator reflex. That means bladder base is supplied by operator nerve when standard TURP with monopolar current is used. When operator nerve exposed to that current, it gives a violent jar and this may jar cause perforation of the bladder. So to obviate or stop this jar, anesthetists usually develop a technique of bilateral operator block along with spinal anesthesia. to prevent this obturator jar and associated risk. There is no tissue available for pathological examination. Optimal candidate for laser therapy is patient with recurrent grade lesion where biopsy is already known. Follow-up is very important or considered as a part of treatment policy in bladder tumor. As superficial bladder tumor develop recurrence, regular follow-up is mandatory. Follow-up is done by cystoscopically as a day care procedure. Recommended schedule for follow-up every 3 months for first year, every 6 months for second, third year, yearly for 4 to 5 years. But when recurrence is found, it should be treated as primary tumor and subsequently it put under surveillance. As the superficial bladder tumors are recurrent, to prevent recurrence, there is schedule for treatment strategy. That is non-muscle invasive tumor treated by immunotherapy. BCG's attenuated microbacterium developed as a vaccine for TB has anti-tumor activity in TCC cancer, TCC bladder, which has been proved that intravesical BCG results in massive local immune response characterized by expression of cytokine, bladder wall and urine, infiltration of granulocytes, mononucleocytes and dendrite cells. These dendrite cells has tumor killer effect and destroy the small tumor. Effective protocol is after 3 weeks of TURBT, when the wound is healed, no active bleeding, then 120 milligram BCG instilled into the empty bladder, dissolved in 60 ml of normal saline, kept for 2 weeks, and it is instilled weekly for 6 weeks if patient can tolerate. If patient cannot tolerate, patient may develop toxicity to the BCG or patient may develop in severe cases frank tuberculosis. In that cases, BCG therapy is discontinued and other mode of intravesical therapy like intravesical mitomycin, thiotepa, etoposide are used, but the efficacy of that intravesical therapy much more inferior than well-established intravesical BCG therapy. Muscle invasive tumor is a broad spectrum of the tumor. 35% of the patient present with muscle invasion. Diagnosis is done transurethral resection, staged by CCT of the abdomen, pelvis, XHS, and bone scan. Radical cystectomy implies removal of anterior pelvic organ in men with bladder with its surrounding fat and its peritoneal attachment, prostate and seminal vesicle in women, bladder and surrounding fat and peritoneal attachment, cervix, uterus, anterior vaginal wall, and urethra and ovary. This remains the gold standard for treatment of the patient with muscle invasive bladder tumor. Bladder reservoir constructed by ileum or ileal conduit. When urethra is free of disease, patient is in younger ileal neobladder, that is, the bladder is constructed by ileum loop, anastomos to urethra. The patient does not require any external reservoir, which is difficult to maintain, sometimes socially not acceptable to the patient. But in that cases, patient selection is important because all this type of patient self calibration of bladder, urethra is to be trained. Otherwise, ileal constructed neobladder may rupture and may life-threatening risk may develop. Cystectomy can be preceded by chemotherapy based on cisplatinum, also called neoadjuvant chemotherapy. It improves survival in a small percent of the patient, provided patient can tolerate chemotherapy and patient respond to chemotherapy. But in a non-responder, it delay the treatment of cystectomy and affect prognosis. In responder patient, it kills the destroy the micrometastasis and improve the survival. Radiotherapy, external beam radiation delivered in fraction for 5 to 8 weeks period is an alternative to radiotherapy in well-selected patients with deeply infiltrating bladder cancer. Treatment is generally well tolerated. Approximately 50% patients may have significant bowel, bladder, rectal complications. But nowadays, linear accelerator, a newer model of radiotherapy technique, has minimal chances of this side effect. Partial cystectomy in very selected patient is solitary infiltrating tumor localized to posterolateral wall or dome of the bladder are candidate for partial cystectomy. Also, patient with cancer in a diverticulum. Disease removed from primary tumor must be excluded by random biopsy preoperatively. As radical cystectomy is a morbid procedure, there is recent trend to preserve the bladder to invasive carcinoma with complete TURBT followed by concomitant chemotherapy and radiation therapy. Cisplatin and gemcitabine have been the chemotherapeutic agent with best radiosensitizing activity in this regimen. This is the treatment schedule for bladder carcinoma. In situ carcinoma, complete dissection followed by intravesical BCG, T1 complete TURBT, TA complete TUR followed by intravesical chemotherapy or immunotherapy, T1 complete TUR followed by intravesical chemotherapy or immunotherapy or radical cystectomy, T2 T4 radical cystectomy, neoadjuvant chemotherapy followed by radical cystectomy followed by adjuvant chemotherapy, concomitant chemotherapy or irradiation. NET, N plus M plus, systemic chemotherapy followed by selective surgery or irradiation. Key points in preventions of the bladder tumor. Stop smoking is the best prevention of the bladder cancer. There is no clear dietary or micronutrient program to prevent bladder cancer. BCG plus high dose vitamin may prevent recurrent bladder cancer. Thank you. এই দেখো তো এক পার্টিসিপেন্ট দেখো তো পার্টিসিপেন্ট হ্যাঁ প্রথম চারটা দেখে দিই প্রথম দিন ৮০ হলো তারপরে ওই ১২২ ছিল কোশ্চেন আসে নেই ঠিক আছে করে দাও তোমরা একবার জিজ্ঞেস করি हाँ धन्यवाद बोल रहे कोई क्वेश्चन नहीं आया ना उधर से स्टूडेंट की तरफ चैट बॉक्स तो ब्लैंक है no question okay thank you आगे কালকেরও তো স্লাইড দিলে